Welcome to this new info masterclass. And my pleasure is to welcome Michel Calamarides from the Hôpital Pitié-Salpêtrière in Paris. Michel is a neurosurgeon. He's already lectured us on NF2 in the past in an info masterclass. And he is here to talk to us about the specific theme of if and when to treat and how for vestibular schwannoma in NF2 schwannomatosis. Before I give the floor to Michel, I'd like to give you instructions for how to interact. You will not be able to interact directly with Michel during the masterclass, but you can do that via the Q&A box or via the chat box, and I will moderate the questions after Michel is done with the lecture. So Michel, the floor is yours.
Thank you, Marco, for your very kind introduction and your invitation. So today we discuss with Marco to talk about vestibular schwannoma in NF2-related schwannomatosis. And it's a difficult question, when to treat and how to treat. As Marco said, I'm leading the National Reference Center for NF2 and schwannomatosis in Paris. It's a French reference center. And we are following more than 400 patients. The first slide is about the new classification. Just to remind that now we don't talk about NF2. I will say NF2 in my talk, but it's formally NF2-related schwannomatosis. This classification was published 2 years ago, and it's a modification of the previous classification done by Garrett Evans. NF2-related schwannomatosis is defined by bilateral vestibular schwannoma or criteria, 2 major or 1 major and 2 minor, and you have all the criteria. So it's based on unilateral vestibular schwannoma with associated tumor. It's very rare to have an NF2 patient without vestibular schwannoma, and there is a molecular definition of NF2 with 2 identical NF2 mutation in 2 different tumors. Just another reminding about the correlation between the genotype and the phenotype, and it's very important to determine the natural history of the disease. And you have this classification. I like this classification based on the genotype. So you have tissue mosaic, you have classic mutation and severe mutation. And I think it's now very important to take in account this classification to manage the NF2 patient, because when there is a patient with a severe NF2 type 3, we know that the patient will face with many tumors, very fast growing vestibular schwannoma, and probably it will change the way to manage the tumor. Just to start, what is the difficulty with the vestibular schwannoma in NF2? It's you have many different clinical situations. You can have a patient with large vestibular schwannoma or very small vestibular schwannoma. It can be discovered in a family of NF2 patient without any symptoms. It can be discovered, like in this example, with a brainstem compression, and the patient can have difficulty with to walk and balance difficulty, hearing difficulty. So it's why it's so difficult to give a flow chart for vestibular schwannoma treatment. It's because you can face with such difficult situation. Another remaining, I will talk today about vestibular schwannoma, but you have to keep in mind that managing an NF2 patient is managing the other tumors, the meningioma, the spinal tumors, the peripheral nerve tumors. So, okay, vestibular schwannoma is one part of the management, but it's all the decisions on vestibular schwannoma are based on the tumor burden and the the other tumors. So it's difficult to reduce NF2 to vestibular schwannoma, but we will do this today. So the last point we'll discuss is this is our experience in France. I think my view on NF2 is shared by the team in England. It's a European way of managing NF2. And I will discuss maybe some difference with the way to manage NF2 in the US, where maybe it's more aggressive, and we'll discuss this later on. I think that to start with vestibular schwannoma, the first most important thing is to understand the natural history. And it's all the NF2 patients we can see are followed at the beginning. So it's very rare to have to treat in emergency an NF2 patient. It can happen, but it's very rare to have to treat a vestibular schwannoma rapidly. And most of the NF2 patients, even with large tumor, are followed by a first MRI and audiometry at 6 months to understand if the tumor is a fast-growing tumor or not. And then if there is no growth, the patient are seen every year. We published this paper, and there are other papers showing that, in fact, when you follow the patient, you see this is the probability to keep useful hearing in one side from a population with bilateral vestibular schwannoma. So at 10 years, you see that 80% can still have hearing at least on one side. This is very important because a lot of decisions of the treatment are based on the fact that at 5 years, if you don't do anything, all the patient will be deaf. I don't think it's true. And it's why I think it's very important to understand natural history, evolution of hearing, and tumor growth. So the question, when to treat, how to treat. We are dreaming, and at the CTF, they are working very hard to find a chemoprevention, because what we would love to have, it's a drug, a treatment that can stop and freeze the situation from the beginning. For the moment, it doesn't exist. So there are some principles. So it's what is important to decide when to treat and how to treat, and we will go in details. I think for me, the first is when it's needed. We need to have the natural history. So there is some trends to treat from the beginning when the tumors are very small, when you discover the tumors by surgery, by radiosurgery, by treatment. I think this is not our strategy. In Europe, it's not the strategy. And I think you need to understand the natural history, tumor growth, hearing, based on audiometry and auditory brain stem response. And I will show you the interest of this examination. The other principle is, I think, is to try to establish from the beginning a roadmap. It is the natural history versus treatment options, the middle and long term. So it is very important, and the patient loves to understand from the beginning what is the next future and the middle or long term. So you have the tumor, it will go in this direction. I think that you will maybe have a surgery or radiosurgery or maybe a treatment, but it's the goal. It's to give to the patient a roadmap as soon as possible. I think that we should use the less aggressive treatment. Surgery is maybe the most aggressive treatment at the day of the surgery, but we will discuss this. And we have to analyze the short and long-term effect, because, for example, for the radiosurgery, it's not aggressive at the beginning, but for example, for the hearing preservation at 5 years, it's not good. So it's, for me, a long-term side effect that we have to take in account. So the principle of the management is hearing preservation, facial nerve function, tumor growth. A lot of discussion are based on hearing preservation, but still the facial nerve function preservation is the most important part in NF2 patient. We have to keep in mind tumor burden and other tumor, and center of excellence. It's a difficult point. I think that my message is that the patient should have an opinion from the beginning to draw the NF2 roadmap, as I discussed before. And sometimes we see the patient at the very late in the disease, when very few options are available. For example, where they had a surgery on one side, the other tumor is very large, the situation is very difficult. I think it's very late. So we are here for such patient, but it will be nice to have the patient from the beginning to discuss all the options from the beginning, because there are window of opportunities. So just to start and to summarize, and I will explain, when you have a patient with bilateral vestibular schwannoma with good hearing, the patient is followed, and then you can have one option, no growth, or a growth on one side, or a bilateral vestibular growth. The two vestibular schwannoma are growing. What we can do? When one tumor is growing, I think that on the first side, it's a focal treatment. When the two tumors are growing, I think there is no place for the focal treatment of one tumor. We should think immediately on the systemic treatment, a drug. But this is not the case when the tumor is growing only on one side, where a focal treatment, I think, is better. And focal treatment, what is it? It's surgery with hearing preservation or radiosurgery. Systemic treatment, it's in Europe for the moment, everolimus, bevacizumab, and particularly bevacizumab if it's associated with hearing loss. And I will go in details in the medical treatment. And I would say that the focal treatment when one tumor is growing is, to do surgery or surgery. It makes sense only if only the vestibular schwannoma is growing. If you have all the tumors that are growing, for example, meningioma, then you can discuss systemic treatment like pregatinib, for example. So we'll discuss. The other situation is a patient with a bilateral vestibular schwannoma with good hearing on only one side. And if you have the growth on the tumor on the good hearing side, I think that you have the only choice is a systemic treatment. Systemic treatment is everolimus of bevacizumab. If you have a growth on the side where there is no hearing, there is still a place to remove the tumor or to freeze the tumor growth by radiosurgery. If the hearing, there is one exception I will discuss later on. If the hearing is declining without vestibular schwannoma growth, what are the options? There is two options. So the schwannoma is stable, but the hearing on this side, the best side, is declining. We can do internal auditory meatus decompression. It's a surgical intervention I will discuss later on. Or you can give bevacizumab. And so I go directly to the medical treatment options. I think for us, the best drug for the moment is still bevacizumab for the vestibular schwannoma, clearly. It was published in 2008 by the MGH group. Why it's good is because it can improve hearing in 1/3 of patients, and it stabilizes the progression of schwannoma in 90%. There is some side effect, but in the young NF2 patient, it's well tolerated, and I think it's still the best drug. You see the evolution of the patient with very fast growing vestibular schwannoma. It was a paper from the UK, and most of the tumors were stopped by the bevacizumab. We published this paper many years ago in NF2 patients with large vestibular schwannoma treated by bevacizumab, and you see the decrease or the stabilization of the tumor in many cases, like for example in this case. You see, this is before bevacizumab, after bevacizumab. Just to know that there are maybe other options linked to the VEGF-A pathway. And this is a paper published this year by a Japanese group, Professor Toda. It's a vaccine targeting the VEGF pathway. And maybe it's promising because in this treatment, you see the growth of the vestibular schwannoma, and it's stabilized like the bevacizumab, but there are less side effects because it's targeting only the vestibular schwannoma, and there is no effect on the kidney, for example, which is the most frequent side effect. So you see the hearing is not improved. It's stable, but I think that we have to follow this new treatment. The other treatment we are using is everolimus. So it's a mTOR inhibitor. There were 3 clinical trials on this drug, 2 in US, in Los Angeles and in NYU, and we have done this. So it's not as efficient as the bevacizumab, but the interest of this treatment, it's an oral treatment. And we observe, as you see, a stabilization, at least during 2 to 4 years. So we are still using this treatment particularly when the tumors are small, growing with a normal hearing. And we show some stabilization. And this is a paper with the same result published by the UCLA team, showing that you can follow after 3 months if the MRI show a decrease in 10% of the size of the vestibular schwannoma. It's a good indication for stabilization at 12 months. So you can give everolimus, and at 3 months, if the MRI show decrease of the schwannoma, you can keep the patient under everolimus for many years. And then, when it's not working anymore, you can switch to Avastin. This is the Intuit master study done in US, and we would love to have such type of study in Europe. So the CTF is working on it. It's a tumor. It's a platform when you treat patients with vestibular schwannoma, others with multiple type of tumor, and you can test multiple drug. So in this trial, the first drug was brigatinib, and the paper came out 2 months ago, a paper from MGA showing that it's a very interesting drug, but mostly for meningioma and non-vestibular schwannoma. You see, the growth of vestibular schwannoma was decreased. So I would say, I'm not the principal investigator, but in my mind, we will use brigatinib when we have patients with multiple growing tumors, including vestibular schwannoma. For only vestibular schwannoma growth, I don't think it's the best drug. There is in US a new study using neratinib. It's a EGF inhibitor, and I know that there are some patients included in the study, and so we are waiting for the first results to know if it works, and we can quickly apply this treatment to our patient if it seems to be interesting. Now I would switch to the surgical options, which remains an important option in NF2. The first thing is, I would say that for surgery, you need a surgeon very experienced in vestibular schwannoma, in sporadic vestibular schwannoma. And for example, now there is a treatment for the small sporadic or medium-sized sporadic vestibular schwannoma, the gamma knife. So the experience in vestibular schwannoma is decreasing. And I review the last 2 years. I did 132 surgeries for vestibular schwannoma, 5 NF2 patients. So you can have a surgeon specialized in vestibular schwannoma for NF2 patient. If surgery is performed, it should be performed by a surgeon very experienced in sporadic vestibular schwannoma and mostly working with ENT. This is just one remark. So I'm starting with palliative treatment. What is a palliative treatment? For me, it's a treatment where you don't remove the tumor. So this is what I was talking before. It's a decompression of the internal auditory canal. The goal is to remove the bone on the top of the internal auditory canal and to open the dura, because the hypothesis is that the cochlear nerve is compressed by the vestibular schwannoma, or originating from the vestibular nerve, another nerve. And if you drill this portion of bone and open the dura mater, it will decrease the pressure in the internal auditory canal. And this technique was performed at the beginning at the House Clinic in Los Angeles, and we perform this surgery in case of patient with stable vestibular schwannoma with decline in the hearing or modification in the auditory brainstem response. And it can stabilize the situation. And so we are using this technique 2-3 times a year, but it can help the patient, mostly in only hearing side. Surgery, why is it difficult in NF2 compared to the sporadic? It's difficult because it's multinodular. There are sometimes many tumors. And you see there is some nodules. So it's more difficult than for sporadic vestibular schwannoma. And I like to show this paper because it explains the difficulty. You see this patient, it was a paper from the Manchester team. You see a patient with a bilateral vestibular schwannoma. It was a patient follow from the beginning of the disease. And you see when the patient was very young, you see 2 different tumors, and you see many tumors arising and growing. So when you see this, you have to keep in mind that in fact there are multiple tumors on many nerves, so it's why it's more difficult than for sporadic. And this is a section of cochlear petrous bone in NF2 patient, and you see a lot of schwannoma in the facial, in the cochlear nerve. So more difficult to remove schwannoma in NF2 patient. It's why hearing preservation surgery for very small tumor, I think it's not so easy, and it can be discussed. This paper was published by the House Clinic by a very experienced team with Daryl Brackman, and their experience is not so good. They are very good surgeons, but even in their hands, they obtain not so good result for the facial nerve, because you see only 84% of grade 1 and grade 2 normal facial nerve in surgeries for very small schwannoma, because you see the small of the size of the schwannoma is 1 centimeter in the internal auditory canal. So in this series of young patients, they did the surgery from the beginning, and they preserve hearing in 60%. And they add, in the follow-up, 5 years later on, 60% of tumor, new tumor, recurrence, I don't know. So based on this paper and this experience, for me, surgery for very small schwannoma and young patient, it's a difficult option and should be discussed seriously. Why surgery is difficult and what is difficult in surgery is the facial nerve function. It's crucial to preserve the facial nerve. Hearing is one part, but the facial nerve function is very important. And it's why sometimes we have to leave a piece of tumor to do a subtotal or partial removal concept, live for sporadic. So now, when we are doing surgery, for me, the most important part is to leave the patient with a normal facial nerve function. If we leave some tumor, we will manage later on the tumor by radiosurgery, by medical treatment, but the goal is to remove as much as possible, but to leave the patient with a facial nerve normal function. And during the surgery, what is very difficult about the facial nerve, if you have a facial palsy, in case of bilateral facial palsy, you have a dysplasia and it's quite impossible to manage. So it was the case before Avastin. Now with Avastin, it modified our strategy and we don't perform frequently surgery on the second side. And when you have a facial nerve palsy, you have a corneal ulceration, and with Avastin sometimes it's difficult. And the other part is a lot of NF2 patients have some part of amblyopia. So when you are doing surgery, you have to know exactly before the surgery the ophthalmic status of the patient, because if you do the surgery on the only good eye, if you have a small facial palsy, it will be a nightmare for the patient. The risk is blindness. The cochlear nerve, the goal is to preserve the nerve, eventually for a cochlear implant later on or during the surgery, but you have to preserve electrically the nerve. So it's difficult to preserve the nerve, even if the patient will not keep any hearing. So if you are able, it's good to preserve the nerve. And then for sure, there is the risk with the cranial caudal nerve and the 9, the 10 nerve, because risk if you damage this nerve is to have a tracheostomy. So it's now it's very rare to have such devastating deficit, but we have to keep in mind. So hearing preservation, there are different options. Hearing preservation, it's gross total resection. When are we trying, in fact, to preserve hearing? It's when the tumor has a medium size and is growing with synchronized ABR on the first side. And we use a retrosigmoid approach. And what are the tools? The tools are the ABR, auditory brainstem response. It's a forensic factor. But during the surgery, it's not easy because you have the response every minute. So it's not helping the surgeon. What is helping the surgeon is a cochlear nerve auditory potential. You put something on the nerve, cochlear nerve, and you have a direct response. If you are damaging the nerve, you can stop in 2 seconds. And if you see a loss of cochlear nerve auditory potential amplitude more than 40%, you have to stop. And then you can have recovery. So in such rare indication, it's very helpful. You see, for example, this patient, bilateral schwannoma, it was growing on the right side. Hearing was normal. We did the surgery, removing all the tumor with hearing preservation, you see after the surgery. And the tumor, you see, this is on the right side before surgery, and we improve the ABR. But on the left side, you see, this is before the surgery, before the tumor growth. You have a normal ABR, but in the evolution, the tumor was growing, and now the patient has no ABR, is desynchronized, and the tumor was growing. So we were discussing surgery or not, and when you have no nice ABR, you know that the chance to preserve hearing are very low. So we decide in this patient for the left growing schwannoma to do radiosurgery. So you see, tumor are growing. It was smaller than on the right side, but because on the ABR, we decide on the right to do surgery, successful, which is the case in 50% of cases, and on the left, growing gamma knife. So the patient had the gamma knife 2 years ago, and we are following for the hearing preservation. Another example of surgery, This is a patient. We did a surgery on the right side, leaving a tumor on the facial nerve, and you see the tumor on the left side growing with a normal hearing. We preserve the hearing on the right side, and we remove all the vestibular schwannoma, leaving a tumor on the facial and cochlear nerve with hearing preservation on both sides. So it's a very good case. It's rare to have a patient with such small tumor, growing tumor with ABR. So it's why there is a window of opportunity, and hearing preservation for us has to be discussed for medium-sized tumor, not for very small tumor, when the tumor are growing with ABR and good hearing. This is my the conclusion, and we need a regular ABR follow-up in addition to audiometry. And you need a experienced and self-confident surgical team. When are we doing partial removal? It's when the tumor are large and symptomatic on the good hearing side. You see this tumor, the patient has no hearing on this left side. The tumor has a balance difficulty, so we decide to remove a part of the tumor. The other, and then we follow the remnant and to treat with Avastin or radiosurgery. And the patient was improved. When the other situation, when we have to decide surgery on the only hearing side, then there is no efficiency of the treatment. This is a patient, she had everolimus, Avastin, and you see the tumor was growing under Avastin. We did a surgery to remove a large part of the tumor. Now the tumor is very small, and we are following again the patient, and the tumor is stable. Another example, this patient was under bevacizumab, and the tumor were growing. We decided to remove this tumor. One small remark, when you have a patient with bilateral vestibular schwannoma, when you remove a large vestibular schwannoma, you can have a growth of the contralateral because there is more space in the posterior fossa. So you see, and then the tumor is stabilized. So we know that when we are removing a large tumor, the other tumor can grow and then stop. So it's nice to have this in the discussion with the patient, and we published this paper many years ago. Hearing rehabilitation, I will not go in details because there was a masterclass on hearing rehabilitation, just to know that we can, even if the patient is deaf, we can have hearing rehabilitation with cochlear implant or auditory brainstem implant. We have, so in case of total deafness, we are performing premonitory tests to predict, and if it's positive, we know that the cochlear implant will be very efficient. And if it's not possible, there is auditory brainstem implant. But to be honest, now with all the possibility, the number of patients with auditory brainstem implant are very low in NF2. So before it was 6 patients per year, now it's 1 every 2 years. Avastin changed completely the game. Radiosurgery, it's working, but less efficiently than in for the sporadic. Also, it's difficult, like for the surgery. And you see in this slide that it's work for the small schwannoma in the older patient, but not for fast-growing schwannoma in younger patient. And the other discussion, there are many papers. It's difficult to understand what is the indication. Is it a proactive treatment on a non-growing tumor? And what is the evaluation? What is the success of gamma knife? Is it to stop tumor growth or no need for further treatment? So it's not well defined. And for gamma knife, we know that can be, the hearing loss can happen in the year following the treatment. This is a recent paper, and you see freedom from additional treatment. The successful of the treatment is lower than for sporadic, and you see hearing preservation is low because at 6 years you have only 50% of the patient with hearing preservation. And another paper showing that maybe it can be linked to the genotype of the patient and the onset of disease. It's more aggressive in the younger patient and in the larger tumor. Last point, the risk of malignancy after radiation. It's something very still debate. It's a paper from the Manchester team showing that radiotherapy is associated with a 5 to 6% rate of malignancy after radiotherapy, whatever the type, proton therapy, gamma knife. Spontaneous malignant nerve was not on the vestibular schwannoma, was NPNST was not published without radiotherapy. So I think that this is particularly true for the young NF2 patient. It should be discussed with the patient, the risk of malignancy. So my conclusion before some question is that first, what is the most important, I think, to treat the vestibular schwannoma in NF2 patient is to understand the natural history. Natural history is the growth of the tumor, but hearing and auditory brainstem response. And we have to work on ABR because it's not frequently performed in US. We are using ABR to follow the patient, and we have to do a work on this to show and to be completely sure that it's very important to predict the natural history of the hearing. For us, medical treatment is indicated in case of bilateral vestibular growth. There is no need for a focal treatment when you have the two tumors that are growing. And frequently, there are patients with multiple opinion. I see patients, they had the first opinion, surgery on the right. The other opinion was surgery on the left because the two tumors are growing. I say, maybe it's time for medical treatment. And medical treatment in the only hearing ear. Nobody will treat a patient with only hearing ear. So it's the place is for bevacizumab or everolimus or other to come. We have to expect in the near future to have other options. Hearing maintenance, it could be interesting in case of ABR decline in non-growing vestibular schwannoma or in case of fluctuation. It's a simple surgery. We don't touch on the facial nerve, on the tumor, on the cochlear nerve. So it's a decompression through a middle fossa approach. Where the surgery is interesting in older NF2 patients, and we are using radiosurgery. Hearing preservation is less controllable, but it can stop and preserve sometimes hearing. So it's another tool. Surgery is indicated for the large tumors, growing tumor, except in some very selected cases with 8 chance of hearing preservation through a retrosigmoid approach. In case of no hearing preservation with a large vestibular schwannoma and bad hearing, it's still a translab approach that is used. So you have to have a surgeon removing tumors through retrosigmoid approach, translab in a team with ENT. There is a place for hearing rehabilitation by cochlear implant, ABI. And the one other take-home message is that expert opinion is needed in this rare disease, not at the late stage to decide if you need bevacizumab or everolimus, but from the beginning, because you have some window of opportunity for tumor removal with hearing preservation, or to decide follow-up, not to rush on a treatment. So I think that is why in Europe we have the chance to have some countries with expert opinion for schwannomatosis, for NF2-related schwannomatosis. So it's very important to have the roadmap and the opinion from the beginning. Thank you, and I think that I am on time, and it's now time for a question.
Thank you, Michel. Can I ask you to stop sharing your screen so that we can have... Thank you very much, Michel. There are lots of questions popping up. There are a few questions which I believe come from patients. The first one is it possible to identify if a vestibular schwannoma is an NF2 one or a sporadic one without genetic testing?
Yes, if there is a sporadic tumor, you have to, if there are other tumor related to NF2 as meningiomas, for example, it's NF2. So one patient with one vestibular schwannoma and two meningioma, it's NF2. Or if you have a sporadic tumor in a young patient before 2025, then you have to do a spinal MRI, ophthalmologic, and test. So yes, clinically, we can make the difference.
And another question, which I believe comes from a patient, is how likely is the regrowth in a patient which has remaining tumor after surgery to preserve the facial nerve?
So you mean what is the strategy to?
Yeah, how likely is the regrowth when when you don't, you just debulk the tumor?
It's more than debulking. First, it's the first surgery is the best. When you go back for a surgery, it's more difficult, clearly. I think that the goal of the surgery, the risk of regrowth is, we don't know exactly in NF2. For the sporadic vestibular schwannoma, if you leave a piece of tumor larger than 0.6 centimeter cube, 5 millimeter, the risk of regrowth is 30% in the next 5 years. So in the sporadic vestibular schwannoma management, the limit is 0.6 centimeter cube. So in NF2 patient, if there is a regrowth, then you can treat by gamma knife or medical treatment. So 0.6 centimeter cube, risk of 30% of regrowth in the next 5 years. Because you can leave a tumor, but you know the growth of the vestibular schwannoma is not like a cancer with growth if you leave some cells. It's more complicated. The growth of the vestibular schwannoma is depending on the vascularization. It's why the Avastin is blocking the vascularization. So sometimes when you do surgery, you coagulate some vessels. It's why when you can leave a small piece, it can be stable for many years. It's why when we are leaving a piece of tumor, we never treat by gamma knife systematically, because a lot of tumor are stable. So it's a balance. So 0.6 centimeter cube, it's a limit.
Thank you. Another question is, can you tell at what age vestibular schwannomas usually develop when you follow children with a known familial NF2 mutation, children that you know from birth that are affected?
How can we make the diagnosis of NF2 in a non-familial from the birth?
I know.
So it's I think that in our experience, it's very rare. We see the vestibular schwannoma from the beginning. So it can be very a small spot, but it does exist from the beginning. So the best case are the familial case, because you know that the patient has an NF2, and when you are performing MRI at age 1 or 2, which is rare because we prefer to do when the patient is older, we can see vestibular schwannoma. So I would say with a good MRI, good MRI is slim and a lot of cut on the internal auditory canal, you see the schwannoma, very small dot.
Yes, and at what age does that typically happen?
For us, I don't know. We recommend in the familial case to do the MRI not before age 6 or 7, when the young patient can understand. So, and we see tumors. The younger NF2 patient I've seen in my life, it was a patient, he was 1 year old, and NF2 was diagnosed because of bilateral cataracts.
Mm-hmm.
And the patient had at that time MRI. On the MRI, vestibular schwannoma. So I see from the beginning. So it's small, it's the quality of the MRI, but now we have, 3-point Tesla MRI. We see a lot of things compared to 30 years before.
Thank you. There are actually many, many questions popping up. I'm starting to have to select them, and I'm sorry. One question from Lisetta Meyer says, I always understood that when growing outside the hearing canal, there is more room to grow, and so there's a chance for a quicker growth.
Can you repeat the question? Because I saw in the same time a question from Amadeo. Can you repeat the question? And I will respond to Amadeo.
Okay.
Can you repeat the question, please, Marco?
Yes, sorry. Oops, Q&A. Now, is always understood, Lisetta has always understood that when growing outside of the hearing canal, because there is more room, then there is a chance of quicker growth, that the growth accelerates.
No.
So then she couldn't understand why the removal of the bone in the hearing canal why does it not facilitate the tumor growth?
I think it's why we are doing the internal auditory meatus decompression in non-growing schwannoma, because we did in the fast growing, and it was not interesting. So I don't know. We are doing this bone and dura mater removal only when the tumor is stable, just to give space to the cochlear nerve. I don't think that the growth is accelerating in the APC. No, I don't think we have the data on this.
Okay, thank you. Now we can jump to Amedeo Aziz's question. So is the surgery more difficult following bevacizumab treatment regarding vessels bleeding? And does it change the tumors histologically or macroscopically?
It's a good question. I discussed with Marco before the talk, and we are working on this with other teams because it's a question. In our experience, I'm not sure. Maybe the discussion is the timing between stopping Avastin and the surgery. Usually we are waiting 1 month. I had discussion with some teams from US regarding some difficulties. So now we are doing a multiple study with 3 other US centers, and I hope that we'll have the response, because it's very important. It's not my impression, but we will analyze. I think the histology is not different. Biology should be different, and vascularization we will see.
And which actually comes to another question, because you mentioned that some patients, after, if they fail everolimus treatment or they start not respond anymore, then they also have the option of going on to bevacizumab. I wondered, what you saw in terms of response, if the tumors that have been treated some form for many years, I suppose, with everolimus, do they respond in the same way as treatment-naive tumors to bevacizumab?
Yeah, it's a case. There is 2 remarks on everolimus. We had the bad experience to stop everolimus when everolimus was efficient. We observe a rebound effect very in a short period of time. So when the everolimus is working, you have to keep. And then when we switch to bevacizumab, it works like de novo bevacizumab. We had a patient in such case when the everolimus was not efficient for the vestibular schwannoma. We stopped everolimus to switch to bevacizumab with hearing improvement and reduction of the vestibular schwannoma. In contrast, the patient had the meningioma, stable under everolimus, and when we stop everolimus, the meningioma was growing very fast in the next year, and I had to remove the meningioma. So it's interesting because we didn't try to combine bevacizumab and everolimus. We are not courageous. I know that there are some patients under brigatinib and bevacizumab. So maybe it's a mix of, it's everolimus. I don't know. At least there is we don't lose chance to put a patient under everolimus for bevacizumab.
And there was another question from Lisette regarding everolimus and bevacizumab. So what are the options if both treatments fail?
It depends how we see there is a trial, so we can use brigatinib, but it seems that brigatinib in such case is not working so much for vestibular schwannoma. Neratinib, and at a moment, surgery or radiosurgery. And my philosophy now is when you are doing a partial removal, if you have a large tumor, if you can remove 90% of the tumor, you can have more years before, to face again a large tumor. So I think that surgery is a good place if the tumor is large, or radiosurgery.
Yeah,
surgery in the past, I'm doing surgery for now 26 years, and I follow patients that had surgery before. It's more rare to see patients with facial palsy. Hearing is a difficulty, but for facial palsy now it's rare because we are more trained for the surgery, and it's not the nightmare. So it's sometimes partial removal to remove a large tumor can be safely. So it's an option for me.
And a question from Amy Jones, who would like to, if you could briefly explain the difference between translab and retrosigmoid approaches for surgery.
Yeah. Translabyrinthine approach is an approach done through the petrous bone. So the ENT is drilling all the petrous bone. So you destroy totally the hearing, because they are drilling all the structure of the labyrinthine. And the interest is you are arriving on the tumor more anteriorly. So it could be more easy to identify the facial nerve. And the retrosigmoid approach is an approach between the petrous bone and the cerebellum. And you have to open the CSF, so there is no drilling, and you can preserve hearing, try to preserve hearing through the retrosigmoid approach. For the facial nerve, now my conclusion is we have the same result for the facial nerve. I like to use the translab approach when the patient has no hearing, or when the hearing is not so good, but when the middle fossa is very small, because when you have no space, it's very difficult to go through the cerebellum and the petrous bone. And then if you go through a translab, you arrive and you see directly the tumor. So these are the approach. We are doing all with ENT. So to do a translab approach, you need to work closely with ENT. Retrosig could be performed by a neurosurgeon alone. So it's why there are some, discussion between the teams. But translab is destroying the hearing.
Thank you. Another question from Amedeo Azizi regarding the malignancy and the post radiation risk of malignancy. He wonders if there's a correlation with the mutation, for example, SMARCB1 versus NF2, or if there are cases where it's indeed more risky.
I think that it's more risky for NF2. And the only study I've seen was done by Gareth Evans' team, focused on NF2 with MPNST arising from vestibular schwannoma or some malignant meningioma for SMARC. And it's very discussed, but when I discuss, for example, with Scott Plotkin, we have a discussion for a young patient. He didn't recommend gamma knife or radiosurgery. He was afraid by the risk of malignancy. So I think that it's very difficult to see clearly the situation. But for me, a young NF2 patient should be discussed. 7% risk of malignancy in the life. For the non-NF2 related schwannomatosis, I don't know. I don't know.
Mm-hmm.
I don't know.
There's another question coming. What is the typical threshold size for a vestibular schwannoma for treatment? Is there a size when, or
Growing,
is it
the growth.
hearing?
We follow patients with large tumor with very few symptoms. So for me, the size of the tumor is not a threshold. It's only, is it growing or not? And how is the hearing? So the size is not a matter of discussion.
Mm-hmm.
The growth.
And I was wondering if there were any, side effects or risks connected to the nerve decompression procedure that you use.
There is some side effects. We had one hearing loss, deafness, at the beginning with drilling of the cochlea. So it was a mistake of the team. And the other risk is the facial nerve, because sometimes in the internal auditory canal, the facial nerve can be pushed on the top by the tumor. And in the surgery, you are drilling the bone, and the drilling, it's hot. The temperature are hot, and then you have to open the dura. Also, we have some patient with some transitory facial palsy because of the location of the facial nerve just under the dura mater, but we don't touch the tumor, so the risk, except the facial nerve palsy, transitory palsy, and cochlea with a good surgeon and with neuronavigation, it doesn't happen anymore. So the risks are limited. It's why it could be interesting when you have, loss, progressive loss of hearing or fluctuation. The patient is taking corticosteroid, it's better, and then it's the hearing is going down. Could be interesting to stabilize, to maintain hearing. We didn't observe any hearing improvement. So it's not to improve hearing, for sure.
We have one last question from Lisette again. In my experience, also systemic treatment failure and pediatric versus radiotherapy always leads to hearing loss. Radiosurgery and focal radiotherapy. Is that a biased experience? Is that your experience too? That one thing, the treatment failure always leads to hearing loss, radiosurgery, and focal radiotherapy. That is a sequence.
Yeah, I think it shows that vestibular schwannoma in young NF2 patient with type 3, severe form, the tumor are fast growing and hearing will be impaired in the next year, particularly if the treatment are failing. So its hearing is more at risk for the young NF2 patient compared to the older NF2 patient. It's a bias. So I think for me that the form in the young patient is the most difficult to manage, because you have some option and medical treatment are not so efficient. So it's why surgery could be an option, but for hearing, it's more difficult. So yes, it's more difficult. It's a bias, but it's more difficult in young patient.
And she also asks if there's one form of radiotherapy that is better than the other, because they seem to have always this debate within our team.
Yeah, I think that in our team too, some radiotherapists think that gamma knife is maybe more dangerous, I would say, rather than proton beam therapy. So we had some young patient treated by proton beam therapy rather than gamma knife. Not sure it was working so much. Yeah. No good option. If we can avoid radiotherapy in a younger patient, it's better, I think.
Well, thank you very much, Michel, for this very lively lecture and very very focused on a very important issue, of course, but very focused. And I thank everyone for having attended and be so participative with the questions. We will post this lecture on the YouTube channel as soon as feasible, so that you can go back to it and see and relook at things that you may have not understood directly, you know, on the first run. We
Thank
will
you.
be.
Yeah. Thank you, and hello to Amadeo, who was following the, the masterclass. Thank you.
And we will be in 10 days' time. There is another info lecture on the management of NF1 plexiforms. And I look forward to updating everybody on the next lectures, on the next info lectures very soon. Again, thank you very much, Michel, for being with us today.
Thank you.
Everyone is sending very nice thank you messages, and I can only share that. Thank you.
Thank you.
Bye.
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 Bye.